My name is Emily Gilman, and I will be addressing migraines. We have Wendy, a 30-year-old woman with chronic migraines, presenting to the clinic with concerns regarding her current medication regimen of vitamin B2, magnesium gluconate, and amilotriptan getting too expensive. She's had these migraines since she was 22 years old. She reports having 3 to 4 migraines a week that she uses 12.5 milligrams of amilotriptan to manage. She's also on 400 milligrams a day of vitamin B2 and 500 milligrams a day of magnesium gluconate. But she reports it's no use though because she's still getting those 3 to 4 migraines every week. She says the migraines last anywhere from 8 to 30 hours, and the pain starts as moderate and develops into severe pain within 1 to 2 hours of onset, with the pain developing behind her eyes and extending backwards. She is a second grade teacher and reports that her migraines are so severe and frequent that it's becoming a real problem with work, and the amilotriptan is getting too expensive, and she's been really stressed with the fear of getting a migraine while she's at work and missing so much of it. She is generally in good health. She had an ACL repair when she was 17. Her mom is 61, and she has hypertension and hyperlipidemia. Her dad is 62. He has depression. She has a 28-year-old brother who is healthy and a 33-year-old sister who has anxiety. Her paternal grandmother is 84 years old, who had a stroke at 63 years old, and she also has hypertension. Her paternal grandfather died when he was 78 due to an MI, and she denies any knowledge of her maternal grandparents' history, but she says she does have a maternal aunt who's 58 years old who also has a history of migraines. She lives in Portland with her husband. They don't have any kids, but they do have 2 dogs. As noted, she's a second grade teacher and says her hobbies are skiing, running, walking her dogs, and hiking. She says she's pretty active and eats well most of the time, eating out about once a week. She denies smoking and reports drinking socially about twice a week. She does not have any allergies. Her vital signs are within normal limits. She weighs 130 pounds and stands at 5'6". She is alert and oriented. She doesn't appear to be photophobia at this time. Her pupils are perla. Her lung sounds are clear to auscultation with no increased work of breathing. She has a regular rate and rhythm, S1, S2, with no murmurs. She has her radial and pedal pulses are +2. Romberg is normal, no Babinski. Her finger to nose is normal. Tandem walking is normal, gait is normal, and her cranial nerves are intact. She did score a 5 out of 5 on the migraine screening questionnaire. Her labs are within normal limits, and she doesn't have any imaging warranted at this time. This is the migraine screening questionnaire. Patients are asked these 5 questions and are asked to answer yes or no. No scores a 0 for that question. A yes scores a 1. Wendy answered yes to all 5 questions, and thus scoring a 5 out of 5 total possible points. So the goal today is prophylaxis of her migraines. She's ready to try a daily medication with the intention of lowering the cost and the frequency of the migraines. So she does have some options here. She could try an anti-epileptic like valproic acid, but they are typically teratogenic, and she is within childbearing age and wants to try to have kids within the next couple years, so she doesn't want to try this one. Tricyclic antidepressants are also an option, but they do have a risk for weight gain, so she's not willing to give this one a shot either. Calcium channel blockers have also been used, but their effectiveness shows mixed results in clinical trials, and it's just not reliable enough for her to want to give that one a go. Selective serotonin reuptake inhibitors, SSRIs like fluoxetine, are also an option, but they do pose a risk for insomnia and are black boxed for suicidality, so that is enough to steer her away from that one. Beta blockers, like propranolol, have been shown to be effective. They are decently priced, and they do have a tolerable side effect profile, so that is the medication of choice. So again, the goal is to reduce the frequency of the migraines, which she's currently experiencing 3 to 4 times a week, and get that cost down. So why propranolol? Propranolol has been shown effective for prophylaxis of migraines at 160 milligrams in clinical trials, with a 44% reduction in migraine activity when daily headaches were used to assess treatment outcomes, and 65% reduction in migraine activity when clinical ratings of improvement were used to assess treatment outcomes. And there is a significant cost reduction when compared to the amitriptyline that she's currently on. The amitriptyline at 12.5 milligrams costs an average of $18.85 a unit, whereas propranolol at 160 milligrams costs an average of $1.49 per unit. So that is a significant improvement. So her treatment plan today is to continue with her adequate exercise and avoid triggers such as stress, overexertion, and lack of sleep. So it's important for her to get adequate sleep and manage her stress. And the medication plan is to continue on the vitamin B2 and magnesium gluconate as she already is on, and implement the 160 milligram dose of propranolol per day. And we will reassess in 6 weeks. If she has adequate outcomes, we will continue on this regimen, and if not, we at that time will taper off the beta blocker and go for something else. So propranolol is a non-selective beta blocker. It acts directly on beta-adrenergic receptors in the walls of blood vessels, including that of the brain. It causes the muscles to relax and thus improves blood flow and slows the heart rate down, lowers blood pressure, and downregulates the renin-angiotensin-aldosterone system. And vasodilation is associated with migraines. Beta blockers antagonize this and reduce cerebral blood flow in the brain, which is thought to play a role in migraine prevention. They do induce a change in electrical activity in the brain that prevents the effect of cortisol spreading depression, which is brain activity that's associated with the early onset of migraines, but the exact mechanism of action in migraines for beta blockers is not yet known. Propranolol is a lipophilic med and is almost completely absorbed when taken orally, but it does have a high first-pass metabolism by the liver, averaging about 25% of the dose reaching systemic circulation. As noted, it's almost completely metabolized by the liver, primarily by cytochrome P2D6 isoenzyme. It crosses the blood-brain barrier, it crosses the placenta, and it does go into breast milk. It has a half-life of 3 to 6 hours, and its peak concentration is within 1 to 4 hours of administration. So potential adverse reactions are fatigue. She could experience cold extremities, blurred vision or dry eyes, constipation or diarrhea, nausea, and she could have decreased libido. There is that risk of sexual dysfunction. Orthostatic hypotension is also a risk. Erythema multiforme, Stevens-Johnson syndrome, and bradycardia, as well as heart failure, pulmonary edema, and bronchospasm are a risk as well. It may decrease the effectiveness of beta-adrenergic bronchodilators and theophylline. It also interacts with dopamine and may decrease the effects of dopamine. Administration of other triptans like zoltriptan and rizatriptan with propranolol can increase the concentrations of the said triptan by 37 to 75%, so that can be a major interaction. And concomitant use of alcohol can increase the plasma levels of propranolol, so that needs to be used wisely if she does choose to do so. And further patient education is that she should take it at the same time every day, particularly in the morning with food, to increase the bioavailability of the propranolol. It's going to be an extended release capsule, so she's not going to want to chew it or crush it. And she should be instructed to be careful changing positions to minimize that orthostatic hypotension, especially on the initiation of the therapy. She will continue on the vitamin B2 and magnesium gluconate as she already was. And should the propranolol not yield the desired results, She's instructed to not abruptly stop the use of it. We'll reevaluate it in 6 weeks, and if the desired effect isn't achieved, we'll taper the drug at that time and consider an alternate therapy. If her pulse is less than 50 beats per minute, she's not going to want to take it that day, and she should give us a call. And she should also keep a log of her headaches, her symptoms, pain level, the duration and onset of the migraines, as well as triggering factors for the next 6 weeks so we can get a thorough evaluation of the effectiveness of the therapy. And as always, she should call with any concerns.